transcending mediocrity in our profession. Welcome back, and thank you for joining me on the podcast today. This is the Dr. Krol PT and Fitness Podcast. I am your host, Dr. Lee Krol, physical therapist. If you're here, you know what to do. Hit that like, hit that subscribe, hit that share it on social media, Facebook, Instagram, LinkedIn, Twitter. Hit that bell so you get all the notifications when I upload new content talking about the topical things in physical therapy, rehabilitation, and fitness. Today's topic is the change of name with physician assistant to physician associate, and what that means for physical therapists, especially the inpatient physical therapists out there in subacute rehab and long-term care. I'm not really talking about acute care physical therapists who work in a hospital. That's a different discussion. But we're talking about the inpatient therapists in rehab facilities specifically, and what this all means for them, and why they should be very nervous about the meteor that might be coming for that side of the profession. I've talked before about two different meteors coming, one on the outpatient side with cookie cutter exercise programs, us being replaced by Google MD, and then on the inpatient side, I talked about a different meteor, and that meteor is now starting to come into light a little bit more with the physician's assistant name change to physician associate. So if you have no idea what I'm talking about, physician's assistants is a sort of mid-level field that works for a physician, under a physician, however you want to call it, and they are, as by name, physician's assistant. They'll see the patients post-surgical or in place of the physician to handle most cases. The physician will review everything, and then the person goes on to their care. The physician's assistant is well-trained and able to handle most cases that come in the door. And if there's anything complicated or anything outside of the norm, they can always go talk to the physician. It's a great mid-level position, right along the level of a nurse practitioner, PA nurse practitioner, that mid-level position. Well, the governing body for physician's assistants hired a research firm, and they did a lot of different research on name changes, and they boiled it down to 4 different names out of 100, I believe was the names that they picked from, down to 4 different names, and they came up with and decided to vote on passing the change of name from physician's assistant to physician associate. Now, this isn't a discussion about whether this is a good thing or a bad thing. I don't really have an opinion on it. I just feel that it's sending physician's associates or PAs to a more autonomous practice where they don't need to be with a physician. Again, good, bad, or indifferent, I don't have a big opinion on that. I'm not part of that tribe. But what does this mean for physical therapists? Because I saw this and I thought it was very interesting. I thought, here it comes. Here comes the meteor. So let's set the table. I talk to a lot of different students, and I love talking to students because they give you really an unbiased view of what's going on. They don't have a lot of biases and pulls. They're not hired by anyone yet. They're students, whether they're volunteering or they're student physical therapists, and they give you a lot of information. So when I talk to students, I'll ask them a lot of times, have you guys done your subacute rotation yet? And I get, yeah, glad that's over with. And I'll look at them and I'll say, okay, is it because 85% of your day was heel slides, ankle pumps, seated marches, long arc quads, hip adduction by squeezing a ball, hip abduction by pushing into a band, and then a 150-foot walk with a wheelchair follow and a 2-wheel walker? They'll put their head down like this. They'll kind of smile and they'll be like, yep, that was my entire day. 85 to 95% of my day was exactly that. And I'll ask the students who are shadowing, like, what did you see? And I'll list off those exercises and they'll be like, yep, they had everybody lined up and it was just one exercise after another, just rotating, and then a wheelchair follow walk for the next resident there at the rehab facility. And that was what we did all day long. Second half of the day, they would do intakes. And intakes at a rehab center, they're not about differential diagnosis. They're about finding out the person's prior level of function, finding out what type of home environment they'll be going to, and what they physically need to do to go to that environment. It's very low level work when it's done at a low level. And I use that qualifier because that's important. We can do this work at a higher level, but overwhelmingly what we see at rehab facilities is subacute theater. Everybody with an HMO lines up over here. There's 4 or 5 of them. And again, it's seated marches, long arc quads, yada, 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 the same exercises I just listed before. And then Medicare is over here because they demand one-on-one, and they're getting the same exact thing, just one-on-one. It's the same exercise, the same treatment. You may have a person in the parallel bars every now and again. You may have a person doing a slide board transfer. You may have someone on the stairs trialing that, but overwhelmingly, that's the type of Therax and Theract and gait training that you get at these rehab facilities. Without question, it's the same thing over and over and over again. It's, again, as far as using your skill set, it's very low on the scale. You're not doing differential diagnosis. You're not really catching anything unusual that nobody else caught. You're not, coming up with a directional preference. You're not looking at things in the kinetic chain where how does the ankle affect what's happening at the shoulder. Really none of that stuff's happening. You're not doing high-level vestibular care. You're not really doing high-level neuro care. It's just very low-level, simple care. And simply put, I could pull a layperson off the street and teach them the psychomotor skills of doing that type of work at that level in about a month. So if that's the case, then these rehab facilities are going to say, well, we're paying a lot of money to these physical therapists, $60,000, $70,000, $80,000 total salary package, which includes all your benefits and everything, to these physical therapists. What if the PTAs got together and said, what if we rebrand ourselves as physical therapy associates or physical therapy technicians, and then we'll do that job because they're under 24/7 nursing care and physician care anyway. The PTs aren't coming up with a differential diagnosis. The PTs aren't coming up with anything high level. They're doing very low level stuff. Why don't we do this? Give us a $5,000 a year raise and fire every PT out there. If you're a rehab facility, especially post-COVID where they were all hemorrhaging money, you're looking at that and you're going, well, $5,000 for the PTA. I mean, the person's under nursing care and physician care 24/7 anyway. Why do we need this PT and their 6 years of education to do heel ankle pumps, seated marches, long arc quads, push out into the band, push into the ball with your thighs, and then a wheelchair follow walk? Why can't PTAs do that? Why can't they just be taught how to do an intake? It's not very hard. What's your prior level of function? Did you walk with a cane, a walker? Were you walking independent? Who do you have to live with? How many stairs do you got to get inside your house? Is there a handrail? One on each side? Can you reach them both at the same time? Do you have to go to a second floor for any reason? Can you stay on the first floor? Where's your full bathroom? This is about the extent of the intake for most places. And again, when we practice at that level, that's what it is. And if PTAs came up and said we could do that with a little extra training, I'd have a very hard time arguing against them. If they're going to make that argument, I can't really say, you can't do this job. I'm like, you know what? We're not coming up with differential diagnosis. We're not using our high-level skills. They're under medical care 24/7 by nursing and physicians. I can't argue against PTAs rebranding themselves, making some extra money, and wiping our jobs out at the same time. I can't argue against that. So if you're a PT, and you've probably already gotten pissed off at me because you're in a rehab facility saying, we do this and we do that, and you're thinking of the hardest case you've ever had, the 1 in 1,000 case where you've caught something unusual, or it was a difficult case, or no, I do some other stuff, not just that. I mean, that's most of my day, but I do some other stuff, and you're getting all pissed off at me. Don't get pissed off at me. I am just a messenger. Getting pissed off at me is like a resident in Florida getting pissed off at Stephanie Abrams and Jim Cantore of the Weather Channel telling them that there's a hurricane coming. They didn't put the hurricane there. They're just telling the residents, get out, there's a hurricane coming. I'm just telling you that if we practice at this level 85 to 90% of the day, that this PTA rebranding asteroid is going to come and wipe your job out. I don't want to see that happen because I think we can do a better job than the PTAs. So one of the things that I want to say is, what do we do about it, right? So if we're PTs and this asteroid starts coming, do we scream and yell? Do we jump up and down and get all pissed off? I mean, physicians tried that when we as PTs were going for direct access. It didn't work. It shouldn't have worked because there's no reason why PTs can't see people direct access. So physicians jumping up and down didn't mean anything. It didn't stop anything. It didn't stop us from getting the access. So if we jump up and down and start yelling and screaming and saying, these PTAs, they can't do this, that's not going to help, because at that level, the PTA sure as hell can do it. There's no reason that you have to pay $60,000, $70,000, $80,000 when you can pay a PTA $45,000 to do that same level of work. So what do? Maybe we raise our level of care at a nursing facility. There are rehab facilities out there who do exactly this. They have a very high level of care. They have excellent physical therapists who are doing things like true aquatic therapy, which means you're actually in the water with the patient. You're not just standing off to the side telling the patient to do something. You're actually in the water doing things. That's aquatic therapy. They're doing real high-level neuro stuff. They're doing vestibular hypofunction training. This is the type of stuff we should be doing. So almost everybody who comes into a rehab facility has a balance issue. They have a gait issue. They have a stair climbing issue. They have some sort of issue that stops their basic functional mobility. And many of them live alone, or are going to be alone for long periods of time, or are going to be with people like their wives or their husbands who are also elderly and can't help them with big gross motor functions. So if you falls are a horrible word at a rehab facility. The floor is a terrible place to be, even though I'm going to make the argument for being on the floor in a second. If you fall at home and you can't get up, to me that is fatal. If you're staying there 3-4 days unsupervised, you're by yourself, no one's coming in, you're not getting Meals on Wheels, you don't have home PT, you don't have home health aides, you're not living in an assisted living facility, you're by yourself, maybe in a senior apartment or whatever, and you fall and nobody hears you and nobody's coming to check on you, you may be on the floor for 3 to 4 days. This happened to my mom's uncle. This is one of the reasons why I bring this up. He went into a nursing center, an assisted living facility, and never came out. And this is what happens when you're on the floor for 3 days by yourself. And why aren't we teaching people how to get up and down from the floor? Why aren't we putting our people at rehab facilities, when appropriate, on the floor? Why aren't we using mats and putting them on the floor and teaching them how to get up and down? Why aren't we doing that? I mean, anytime you put someone on the floor in a rehab facility, the whole place goes crazy. Oh my God, why are they on the floor? Did they fall? We have to fill out a bunch of paperwork. Was it a near fall? Was it a real fall? What happened? If they're on the floor with physical therapy, that's the best time for them to be on the floor, because then we can teach them how to get up and down from the floor. We can give them strategies on how to do it, and we can make them less afraid of being on the floor. Why we're not doing this almost every single time in a rehab facility is absolutely beyond me. But seated marches, ankle pumps, long arc quads, 150-foot walk with a wheelchair follow, this is the standard, even though we should be really working with people on the floor. If they have a balance issue, which an overwhelming majority of people have a balance issue in a rehab facility, the first place you work on balance is in the crib with neurodevelopmental perspective, rolling. So why aren't we getting people at rehab facilities through neurodevelopmental perspective? Why aren't we getting them on the floor? Why aren't we teaching rolling? There's no weight bearing problem with a roll. They're not going to fall. They're already on the floor on a mat. Why don't we use rolling? Why don't we combine the two? Or hey, we teach you how to get up and down from the mat, or we assist you as needed, but we also start working on rolling. We work on quadruped. We work on crawling. We work on navigation. In case they do fall, now they have tools to get up from the floor or to get somewhere where they can get help. Get to a cell phone, get to a window, get to a door, get to wherever. Teach them rolling, quadruped, half kneeling, work on balance from all these positions, which will translate, because it's as close to a hardwired balance position as we have, or balance patterns we have, that will translate to the gait pattern, which it does from birth, from 0 days old all the way up to ambulation, which is about 12 to 14 months. This is how we get it, by being put in different positions, tummy time, on our backs, on all fours, and eventually up to our feet. Why aren't we doing this with our residents? Why aren't we doing this with our people to get their balance better, instead of ankle pumps, long arc quads, seated march, etc., etc., etc.? Why are we sticking with the cookie cutter garbage, which doesn't really work? And why aren't we doing the neurodevelopmental perspective stuff, teaching them how to get up and down from the floor, working on their balance from a neurodevelopmental perspective? On top of that, an overwhelming majority of people, especially the elderly, in a rehab facility, have vestibular hypofunction. And this is a big component to their balance. They're walking, they turn their head, they lose their balance, and they stumble. It has nothing to do with leg strength. Overwhelmingly, when I see people for balance, has nothing to do with strength. It has nothing to do with, okay, we're gonna, put this yellow band around your thighs, we're gonna push out, and that's gonna make your glutes, especially that, glute medius, we're gonna make that glute medius work a lot better and stronger. It's very seldom a glute medius strength problem. It's usually a coordination, vestibular, balance issue that has to do from more neurological issues than it does from actual strength. So why aren't we working with vestibular hypofunction? Why aren't we doing and checking saccades and checking VORs and adding them as needed to people? Why aren't we doing this type of stuff? Why aren't we working on cervical mobility? Why aren't we working on these type of things? Moving your head. If you can't move your head very far, then you're going to be limited in your VOR. You're going to be limited in just your entire turning radius as it is, because you turn your head, now you have to start turning your whole body to see where you're going or see what you're looking at. And again, this all influences your balance. So if we pick option A of just jumping up and down saying this level of care is worth $60,000, $70,000, $80,000, it's not going to work. We're going to be out of a job really fast. Well, you're going to be out of a job really fast. I'm not. But you're going to be out of a job really fast if you're down here practicing this level saying PTAs can't do this, when we all know damn well that with a little bit of extra training for the intake, they certainly can practice at this level for a lot less money. Or we can take this level and say, okay, we have some Therex stuff, and some of it's pretty good, some of it's appropriate, but why don't we really start working on neurodevelopmental perspective? Something the PTAs are going to have a harder time explaining and a harder time doing. Why don't we start working on getting up and down from the floor, that gross motor function? Why don't we start adding on vestibular hypofunction retraining? And now we're practicing at a level that PTAs are going to have a hard time matching with their education. They're not going to be able to do this, not as easily as we can. This is going to be easy to defend. This level of care is impossible to defend, from a PTA takeover. So if you're at a rehab facility, I want you to really think long and hard about how you're treating and what you're doing. Are you doing the things that a PTA can't do? I want you to look at your PTA when you go to work and say, how long would it take me to train them how to do an intake? Meaning, how long would it take to train them to take my job from me for probably $5 to $10 grand more on their salary, meaning about 10 to 15 grand less than what the facility is paying right now? It probably wouldn't take very long. The psychomotor skills of practicing at this level are very low. And again, I'm asking you to come up. I don't want to bring anybody down. Come on up. And then they can't take our jobs. They can't be rebranded like the PAs were into PTAs, physical therapy associates, and then take your job, which is exactly what's going to happen if you keep practicing like this. And again, I've been in rehab facilities. I know how they work. I'm a physical therapist. I understand exactly how this works. I know exactly what goes on at an overwhelming majority of these facilities. I talk to the students, they tell me the same things. I talk to volunteers and they tell me the same things. They have no stake in the game. They don't get anything for saying, yeah, I went to my rotation at a PT clinic, a rehab facility, subacute rehab, and by the second day I was independent and I wasn't learning anything by the end of the first week. This is a story I hear all the time. These aren't people that talk to each other and say, hey, we're going to tell Dr. Krol the same story so that he can go on the podcast and rant and rave about it. No. I'm hearing this story from people who don't even know each other. I'm hearing this from patients of mine or patients' friends of mine who are saying, hey, can you come to the rehab facility because I don't think we're really doing a lot at rehab. And obviously I can't do that. The rehab facility is not going to let me in. But I have people that are saying, I want to take them out of the rehab facility and come to see you because I know you're going to do a higher level job. And the reality is, there's nothing about me that is interesting compared to my colleagues. I just practice at a higher level. I just choose to practice up here. And there's no reason my colleagues can't. So if you don't want your job to get wiped out, bring yourself up. Bring yourself up to a level where you can't be wiped out by a lower paid, lower educated individual. It doesn't mean that PTAs are bad. PTAs are perfectly fine. and they can do this job. I mean, I'm defending PTAs here and saying they could do our job at a rehab facility when we practice at this level. Again, I talked about acute care very briefly. I take that out of the equation because acute care, we really do work a lot with the physicians, differential diagnosis, coming up with things and really, adding into the medical team diagnosis. So I think that's a realm where we're pretty safe at, as long as we, really have that type of communication with the physicians and the rest of the med team. But as far as inpatient subacute rehab, again, if 85% of your day is hip abduction into a band, hip adduction into a ball, seated march, long arc quads, ankle pumps, and 150-foot walk with a wheelchair follow, we are setting ourselves up to be whacked by PTAs, rebranding themselves as physical therapy associates. So if you saw this physician assistant to physician associate change, that should have scared the hell out of you if you're practicing at this level. The meteor's coming. We can stop it by raising our level of practice. That has been an overarching theme of my podcast ever since day one. You can go back to the beginning where I talked about devaluing the PT profession. This is exactly what I'm talking about. We will get wiped out if we don't raise our game. We have the ability to do so. We have the education. We got the doctorate for a reason. It's time that we start practicing at a doctoral level so that people who don't have doctoral level education can't take our jobs from us. Thank you very much for tuning into the podcast today. If you liked what you heard, hit that like, hit that subscribe, hit that little bell, share it on social media. If you disagree with what I had to say, that's fine too. Leave a comment. Let's bring some conversation into this thing. We'll talk about it. I have no problem bringing people on if somebody wants to come on and defend what they're doing at a rehab center. If they're practicing at this level and they want to defend it, just don't come in here defending it by blaming the insurance companies and the administrators. You're autonomous practitioners with your own license. You can practice at whatever level you choose to practice at. So don't blame it on anybody else. If you want to come on here and defend it, I'll be more than happy to have you on, and we'll talk back and forth about it. Maybe you'll change my mind. Maybe there's something I'm not seeing. That's why we have this podcast. That's why we have this discussion. I hope to see you next time on the podcast. This is Dr. Lee Krol, PT, signing off, and I'll see you next time.